Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Manoj Toshniwal. Sir is MBBS, MD Internal Medicine, DM Clinical Hematology, PMT Fellowship, Consultant Hematologist at Jeevan Amrut Hospital, Aurangabad. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is overview and management of sickle cell anemia. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
So thank you so much, IJCP Group, for organizing such a good webinar. And apologies from me. I miscalculated it. I thought it is on 7 p.m. and by 6 I got to know that at 6 today. So I got a little bit late. Without much delay, let's discuss today about sickle cell anemia. Today is 19th of June, and across the globe, this day is celebrated as Sickle Cell Awareness Day, where we spend some time in thinking what sickle cell anemia is, how to treat those who are already suffering from sickle cell anemia, and how to prevent birth from sickle cell anemia. Because it is a preventable disease, it is a genetic disorder where if we know the genetic status of your own by avoiding marriage between sickle cell minor or sickle cell major, or if they are already married before birth, if we diagnose the baby by chorionic villus sampling or amniocentesis, if someone has sickle cell, we can avoid the birth of. So today is the day, 19th of June, World Sickle Cell Anemia Awareness. That is a altogether different thing. I welcome all the physicians, pediatricians, all the clinicians who have joined, who are keen to know how to manage sickle cell anemia cases. So today we will be discussing overview and overall management of sickle cell anemia. So normal hemoglobin is where we have the HbA and HbA2 chains, which are like made up of alpha 2 and beta 2, HbA. These are four chains which hold four hemoglobin molecules, four iron molecules which bind with the oxygen. Normally, there are more than 700 structural hemoglobin variants identified. When it is alpha 2 beta 2 chain, it is the main component of our blood. We call it as HbA. There is some quantity of HbA2 where alpha 2 and delta 2 are there. It is 2 to 3% in adult hemoglobin. Whenever there is iron deficiency anemia or nutrition anemia, HbA2 value goes down. If it is thalassemia minor, HbA2 value goes up. That is around the 4% to 5%. HbF is alpha 2 and gamma 2. It is gradually decreased after 2 years and only in adults increases 0 point something like. So whenever there is increased level of HbF, we are worried why it is there. It can be because of the stressed hematopoiesis in patients who have normal pregnancy, myeloproliferative disorder, various leukemias, even in some sickle beta thalassemia and sickle cell anemia cases. So HbF level can also be high in such cases. So what sickle cell anemia is? So this is how the hemoglobin structure is there, and various hemoglobinopathies where we have quantitative or qualitative disorder in the hemoglobin, we call it as hemoglobinopathy. Qualitative means where quality of that hemoglobin is different, where there is structural abnormalities in the synthesis of HbF. There is alpha 2 and beta 2, which is normal, more hemoglobin variant it is changed to something else. That is structural abnormality is there. We call it as we call it as qualitative defect. If there is quantitative decrease where HbA2 is not getting manufactured properly, we call it as quantitative defect, that is thalassemia. Okay, so whenever there is structural abnormality, we call it as qualitative, that is sickle cell, HBC, HBD, HB Iran, various H. And whenever there is quantitative disorder where decrease in globin synthesis in hemoglobin, we call it as thalassemia. Okay, so this is how we divide the hemoglobinopathies. So sickle cell anemia is actually a qualitative defect in your hemoglobin because of some genetic changes. You have this structural defect in your hemoglobin and your hemoglobin is low. So, sickle cell disease is a hereditary hemoglobinopathy which is characterized by autosomal recessive inheritance, and there is decrease in production of oral hemoglobin because of the defective hemoglobin. This happens because of this point mutation at the sixth position of beta globin chain, where glutamic acid is replaced by the valine, G is replaced by the V, and the beta globin chain becomes HbS. So this alpha 2 beta 2 becomes alpha 2 S2 actually, where there is glutamic acid is replaced by the valine at the sixth position of beta globin chain, leading to this hereditary hemoglobinopathy. Sickle cell is not just one disease, it is a heterozygous disorder where we have 3-4 variant actually, many more than that. Whenever there is only 40% is HbS, that is called a sickle cell trait. They are asymptomatic carrier, they don't develop any symptoms lifelong. HbS percentage is usually less than 40%. They have only one gene which is defective and they remain heterozygous for life. Homozygous state is when sickle cell anemia is there, where HbS can be more than 50%, up to 80%, even 90%, but usually it is stress hematopoiesis which leads to more HbF, and there is homozygous HbS percentage. That is called as sickle cell anemia. They are symptomatic, they need treatment, they have problems. Some are like double heterozygous, where they have sickle beta thal, where HbS percentage will be around 40-50%, HbA2 will be on higher side, HbC can be there, HbD can be there. So these are double heterozygous states of HbS. This is how they inherit. HbA is normal hemoglobin. It is substituted by the sickle hemoglobin in sickle cell trait. Both the parents have sickle cell minor, where they are heterozygous for sickle, asymptomatic, and by this they make HbS in 25% of cases, sickle cell minor in 50% of cases, and normal in 25% of cases. So typically, no blood disorder, sickle cell minor, or sickle cell disease can be there depending upon the inheritor. What is the pathogenesis? Why HbS people have symptoms? So, main purpose of our hemoglobin is to carry oxygenation. It supplies oxygen everywhere. So, deoxygenated HbS molecule undergo aggregation and polymerization. Whenever there is deoxygenation, less oxygen is there, it becomes sickled RBC. So, initial sickling is reversible, but if oxygen is not provided, it gets irreversible sickling. That Repeated sickling leads to the membrane damage, leads to the hemolysis, and also it leads to the permanent sickling problem because of repeated sickling crisis. So, normal hemoglobin carries oxygen, but if sickled hemoglobin is there, it doesn't carry oxygen properly. That deoxygenation leads to recurrent aggregation and polymerization that leads to the sickling episode, damage, hemolytic anemia, all those. So, normal hemoglobin is like this, normal RBC is like this. Whenever there is deoxygenation, there is decrease in pH, O2 is not binding with the proper, and it leads to the sickling of RBC. Sickle means sickle shape. It is the shape of your sickle. They become sickled, it causes membrane damage, it leads to the hemolysis. These are the normal RBCs. You can see the center pallor under the microscope. They have typical shape. But whenever there is sickling, this is how they shaped. So deoxygenation of SS isocytes lead to the intracellular hemoglobin polymerization. That leads to the loss of deformability of RBCs and change in the morphology of cell because of the polymerization. Because of the polymerization of hemoglobin due to deoxygenation, they lead to the loss of deformability of these RBCs and change in the morphology. Factor those influence the rate and degree of sickling. Most important is the whenever there is heterozygous state, they are asymptomatic unless severe hypoxia is there. Whenever there is homozygous state, full-blown sickle cell anemia can be there. It is because of the whenever there is some deoxygenation, they lead to the infection, dehydration, all this. Rate of HbS polymerization is strongly depend upon the Hb concentration per cell, that is MCS. So whenever there is dehydration, MCSC increases, it increases the sickling, it leads to the more hemolysis, decreased globin synthesis, and there is decrease in pH. Whenever there is acidic atmosphere, because of the decreased affinity of hemoglobin, there is increased sickling. So, decrease in pH of the blood, decrease in the water content of the blood, overall homozygous and heterozygous state, depending upon the what else is there, like sickle beta thal is there, it reduces the globin synthesis. Because of that, MCSC is also low, and if MCSC is low, milder disease will be there. So, fourth thing is length of RBC exposed to the low oxygen. So sickling of red cells is confined to the microvascular beds where blood flow is sluggish. In large vessels, there is fast flowing blood, oxygen, low oxygen tension is less. So that is the inflammation, red cell agitation lead to the longer red cell transit and sickling. So whenever there is inflammation in the body, that leads also to the sickling. Sickling is actually a natural protector from the malaria because patients with HBS are relatively protected against the falciparum malaria. It selectively got the Darwinian or selection, and plasminogen infects RBCs and induces quicker sickling. Sickle RBCs with parasite inside them are sequestrated in the spleen, thus providing protection. So, actually, naturally, it got selected, but and that is why it is common in areas where there is prominence of malaria, like Nagpur, the Soegaon district of Aurangabad, some tribal areas, because gives natural protection against the malaria, they get survival advantage. Sickle cell anemia morphologically, usually they come with this chronic hemolysis, hyperbilirubinemia, microvascular occlusion, and thrombosis. That leads to the expansion of bone marrow, leading to the bone resorption, secondary new bone formation, prominent cheekbones, changes in the skull. Spleen early phase can be splenomegaly, but with recurrent tracking and sequestration, they lead to the autosplenectomy, that is progressive shrinkage of the spleen because of the recurrent thrombosis, and that leads to the autosplenectomy, leading to the recurrent infection in these cases. Overall, on peripheral smear, you can see sickle cells and target cells, features of splenic atrophy like oval jelly bodies, nucleated RBCs. You do the sickling test where mixing of blood sample with oxygen consuming reagent like sodium bisulfite induces the sickling of red cells if EHBs is present. As we have already discussed, deoxygenation leads to the more sickling. Reticulocytosis and hyperbilirubinemia will be there, and EHB electrophoresis will show prominence of EHBs, where EHBF will also be on higher side. More the EHBF, lesser the symptoms. More the HbA2, lesser the symptoms because of the increase in MCHC and less dehydration protection from the oral sickness. But the diagnostic clue usually you get from the clinical side, where patient comes with chronic hemolysis, chronic hyperbilirubinemia, chronic bony pain, thrombosis, bone resorption leading to the bone changes, splenomegaly. You do the peripheral smear, you see these target cells, sickle cells, Howell Jolly bodies. You do early sickling by sodium metabisulfite, it is positive. Late sickling is positive. You do the smear, reticulocytosis, hyperbilirubinemia is there, and you do the electrophoresis, HbS percentage will be on higher side. This is how the peripheral smear looks like. The typical peripheral smear of HB, the sickle cell disease, where you get this sickled RBC. This is sickled RBC. This is sickled RBC. This is also sickled RBC. This is also sickled RBC. You get this sickled RBCs along with nucleated RBC. This is nucleated RBC. You can see these target cells as well. These are all typical sickle beta cal or sickle cell anemia. Okay. The second smear is also classical sickle cell RBCs are there. You can see these sickle cell RBCs are there. You do this splenectomy, autosplenectomy happens because of shrinkage of the spleen. It's normal splenic size and it is shrunken. So, because of the recurrent thrombosis, they develop various symptoms in long term, and that is why the sickle cell is something which all should be aware, which all should be taking care of. Because of recurrent thrombosis, they develop cerebral infarct, stroke, mental retardation, pulmonary infarct, recurrent pneumonia, splenomegaly, splenic atrophy, sickle retinopathy, sickle cardiomyopathy, sickle congestive cardiac failure, polylithiasis, renal infarct, hematuria, infarct in the extremities, vaso-occlusive crisis, non-healing ulcers, bone marrow hyperplasia, osteomyelitis. These are various manifestations of sickle cell disease, and because of that, they are recurrently coming to the hospital. They get hospitalization, they get admitted, they need treatment again and again. Okay, so these are the main. So clinical features: chronic hemolytic anemia, episodes of aplastic crisis, vaso-occlusive complications because of the hypoxic injury, markedly impaired dysfunction of spleen leads to the increased infection by encapsulated organisms like meningitis. These are various manifestations of sickle cell. So, factors that can cause sickle cell crisis. If more than 3, 4 crises are there, need recurrent admission, we go for transplant, otherwise not. These are the various things which can lead to the recurrent crisis like infection, deoxygenation, concomitant medical treatment like herpes, diabetes, all those things, dehydration, acidosis, extreme physical exercise, psychological or physical stress, alcohol, pregnancy, cold weather. These are the various precipitating factors for sickling crisis. So, this is how the sickle cell is. This is the overall overview. How to treat, second thing which we will be discussing. How to treat them? It is by first thing, there are various newer drugs coming into the market, but most important is the patient education. By saying them, these are the factors which you should avoid so that recurrent sickle cell crisis doesn't happen. Second thing, hydroxyurea. We doesn't know how exactly it works, but there are various mechanisms. Most probably, it decreases sickling by increasing the HbF percentage by marrow stimulation. HbF percentage is more, the less sickling is there, less crisis is there. If they are on recurrent crisis, you need to treat the crisis at that point of time, and maybe vaccination, transplant, all those things are there. Second thing which we will discuss is about prevention of sickle cell anemia. Prevention is by medical education of the masses. The areas where sickle cell anemia is prominent, there should be mass campaigning, social awareness should be increased. Patient should know his status of sickle cell trait. If someone has sickle cell trait, she should avoid marrying with sickle cell trait person. If marriage has already happened, maybe prenatal diagnosis there. So these are the various methods by which sickle cell oral predominance can be decreased, prevalence can be decreased. So today is 19th June. It is sickle cell anemia awareness day. Let's pledge we all will increase awareness of sickle cell anemia in the community. We will try to treat those patients who are already suffering from sickle cell anemia rightly and guide them for a happy and prosperous life. Thank you so much. So session is open for the question and answer. Thank you.
Thank you so much, sir, for answering all our questions. Sir, for your wonderful presentation, sir. So, sir, we do have some questions if you like to take that up.
Yes, please.
So, sir, the first question is, what are the key components of patient education for individuals with sickle cell anemia to enhance self-management and adherence to treatment?
So very important question. Sickle cell disease is a chronic disorder, lifelong disorder. By birth, patient has sickle cell anemia. Lifelong, they are going to have the recurrence. Psychological issues are more. They are depressed, they are suffering, and that is why they keep on changing the doctor. Multiple treatment interruptions are there. They need good patient education for sure. Encourage them for the regular medical follow. Encourage them to understand what are the warning signs of sickle cell crisis. What are the things which can precipitate the sickle cell crisis to avoid, and help them, motivate them so that they can live the normal life. Second thing, prevention. Those who have sickle cell, it is a genetic disorder. Usually it runs in the family. So family screening is also important, so that in the family someone has sickle cell, all others should also be tested. They should be educated about the marriage, prenatal diagnosis, how to avoid a baby born with sickle cell, how to taken care of sickle cell anemia cases. And those who are suffering very badly, maybe they can guide it for the bone marrow transplant. Thank you.
So the next question is, what are the indication for bone marrow or stem cell transplantation in sickle cell anemia, and what outcome can we expect?
So thank you so much. This is very important question because sickle cell is a lifelong disorder, as I have told. It is genetic disorder. Sickle cell and bone marrow transplant can be one more topic of discussion, one more webinar. But just to keep it in a nutshell, those patients who are suffering a lot with recurrent admissions where life expectancy can be reduced to significant extent, they only can go for transplant. They should only be guided for transplant. Not everyone. I feel less than 5% of them usually go for transplant because transplant itself is like a disease where financial things, availability of donor, patient psychological capacity, the outcome of transplant, everything depends on the situation. If someone is suffering a lot, recurrent hospital admission, recurrent blood transfusion, recurrent hemolytic crisis, life threatening hemolytic crisis, those patients only need bone marrow transplant if HLA match sibling donor and finances are not the problem. Thank you.
Thank you. So there is one last question.
Yes, please.
What chronic complication should clinician monitor for in patients with sickle cell anemia, and what prevention strategies can be employed?
Yeah, so very important question for all the clinicians here. So whenever a patient has sickle cell anemia, they are bound to develop chronic complications for sure, like retinopathy, like nephropathy, like pulmonopathy, like sickle hepatopathy, sickle bone disease, autosplenectomy, and even cardiomyopathy and pulmonary hypertension. Usually for sickle cell anemia patient, we keep them on hydroxyurea, folic acid, calcium for lifelong. Every year we should ask them for the urine microscopy, liver function, kidney function, 2D echo, pulmonary function test, and overall bone density test. These are the chronic complications which all should watch for. Encourage them to take more and more fluid so that dehydration can be avoided and these chronic complications can be avoided. Retinal examination is also important to search for the sickle retinopathy by the expert uh, vitreoretinal surgeon. So these are the chronic complications we all should be evaluated every year once the age is more than 20. Thank you.
Thank you so much, sir. That's all from our audience, and thank you so much for answering all our questions. So, sir, before concluding, any last remarks from you?
So first of all, I thank IGCP groups for arranging such a nice informative session today discussing on sickle cell anemia. Today is 19th June, Sickle Cell Anemia Day. We all should place that we will take care of sickle cell disease cases. We should look for the patients who are suffering. We should guide them, support them. We should take our part in social awareness where we can decrease the prevalence of disease, where we can decrease the complication associated with disease, where we can plan for the long-term strategies for this. Thank you so much. This is all.
Thank you so much, sir, for joining us today. And with your permission, sir, I would like to conclude this session.
Yes,
Thank
thank
you.
you.